So now join us for anatomy of the lower airway. As you'll see in this figure, we have the hyoid, the larynx. And we just discussed those in the upper airway, the last video. And now we're starting into the trachea, the primary bronchi, right and left, the right mainstem bronchus, the left mainstem bronchus, lung tissue to include the alveoli, the carina, the division between the right and left mainstem bronchus. And we mentioned the upper airway having a C-shaped cartilage with the smooth muscle to the back, the tracheal cartilage, the mucous cartilage, the respiratory epithelium, the lamina propria make up the respiratory mucosa. As we move on to the anatomy and physiology, the right mainstem, we'll discuss how the right mainstem often site of aspirated foreign bodies, respiratory bronchioles terminate at the alveoli, oxygen carbon dioxide gas exchange takes place within the alveoli, and atelectasis or alveolar collapse. So as we get to talking about this, we're going to start at the beginning. We'll start at the trachea. The lower airway extends from below the larynx to the alveoli. This is where the respiratory exchange of oxygen, carbon dioxide occurs. Helpful landmarks are the fourth cervical vertebrae at the posterior superior border and the xiphoid process anterior inferiorly, although the posterior lung extends beyond this inferiorly. So the back of the lung extends beyond that to the rear. The trachea, as air enters the lower airway from the upper airway, it first enters and passes through the trachea. The trachea is a 10 to 12 centimeter long tube that connects the larynx to the two mainstem bronchi. It contains cartilaginous C-shaped open rings that form a frame to keep it open. The trachea is lined with respiratory epithelium containing cilia, mucus-producing cells. The mucus traps particles that the upper airway did not filter. The cilia then move the trapped particulate matter up into the mouth, where it can be swallowed or expelled through coughing or exhaling. As we move into the bronchi, at the carina, the trachea divides or bifurcates into the right and left mainstem bronchi. The right mainstem bronchus is almost straight, whereas the left mainstem bronchus angles more acutely to the left. Because of this, the right mainstem is often the site of aspirated foreign bodies. In addition, when the endotracheal tube is inserted too far, it tends to enter the right mainstem bronchus, thus ventilating only the right lung. Mainstem bronchi enter the lung tissue at the hilum and then divide into secondary and tertiary bronchi. The secondary and tertiary bronchi ultimately branch into bronchioles, or small airways. The bronchioles are encircled with smooth muscle that contain beta-2 adrenergic receptors. When stimulated, these B2 receptors relax the bronchial smooth muscle, thus increasing the airway's diameter, or bronchodilating. This bronchodilation can increase the amount of air transported through the bronchiole. Conversely, parasympathetic receptors, when stimulated, can cause the bronchial smooth muscles to contract, thus reducing the diameter of the bronchiole. This bronchoconstriction can inhibit the movement of air through the bronchiole. After approximately 22 divisions, the bronchioles turn into the respiratory bronchioles. The structures contain only muscular connective tissue and have limited capacity for gas exchange. The respiratory bronchioles terminate at the alveoli. So two pulmonary lobules, the lung parenchyma, the lung tissue. The two pulmonary lobules, they are the anatomic division of the lungs. The pleura, the membranous connective tissue that covers the lungs. And as we're Continuing to discuss and talk about pediatric, the pediatric airway is smaller in all aspects, softer and more fragile. They have not had time to strengthen as they are still growing, so things still need to stay soft and pliable. The ribs and cartilage of the pediatric thoracic cage are often softer and more pliable. We know this as if you've ever done CPR. Older you get, the more difficult it is, and the more popping and cracking things you feel. So atelectasis can atelectasis can occur if surfactant is insufficient or if the alveoli are not inflated. No gas exchange takes place in atelectic alveoli, or collapsed alveoli are pinched together, not allowing air exchange, thus not allowing gas exchange at the capillary level. The lung parenchyma, the alveoli are at the terminal ends of the respiratory tree and functional units of the lungs. As such, they are the core of the lung parenchyma. The lung parenchyma is arranged into two pulmonary lobules that form the anatomic division of the lungs. These lobules are further organized into lobes. The right lung has 3 lobes, the upper lobe, middle lobe, and lower lobe. The left lung, which shares thoracic space with the heart, has only 2 lobes, the upper lobe and the lower lobe. The pleura, the membranous connective tissue called pleura, covers the lungs. The pleura consists of 2 layers, the visceral and the parietal. The visceral pleura envelops the lungs and does not contain nerve fibers. In contrast, the parietal pleura lines the thoracic cavity and does contain nerve fibers. The potential space between these 2 layers, called the pleural space, usually holds a small amount of fluid that reduces friction between the pleural layers during respiration. Occasionally, the pleura can become inflamed, causing significant pain in respiration. This condition, called pleurisy, is a common cause of chest pain, particularly in cigarette smokers. As we discussed, the pediatric airway is fundamentally the same as the adults, but you will need to know the differences in relative size and position of some components. The airway is smaller in all aspects, particularly in the diameters of the openings and passageways. In the pediatric pharynx, the jaw is smaller and the tongue is relatively larger, resulting in greater potential airway encroachment. The epiglottis is much floppier and rounder, more omega-shaped than leaf-shaped. The dental alveolar ridge and the teeth are softer and more fragile than in adults and potentially more subject to damage from airway maneuvers. The larynx lies more superior and anterior in children and is funnel-shaped because the cricoid cartilage is underdeveloped. Before the age of 10, the cricoid cartilage is the narrowest part of the airway. Most significantly, even a small foreign body or a limited degree of swelling in the pediatric airway can be life-threatening. Because of this, young children tend to suffer more problems related to the trachea than do older children. A common example is croup, or laryngotracheal bronchitis, a viral infection that causes the soft tissue below the glottis to swell. This can reduce the diameter of the airways, potentially causing serious problems. The ribs and the cartilage of the pediatric thoracic cage are softer and more pliable. This lack of rigidity lessens the thoracic walls and accessory muscles' ability to assist in lung expansion during inspiration. As a result, children tend to rely more on their diaphragms for breathing. Always pay close attention to the differences when treating pediatric patients, especially those with respiratory complaints. You want to watch within the the rib cage. You want to watch between the ribs. You want to watch for that accessory muscle use. You want to watch in the sternal notch. You want to watch near the clavicles, at the top of the rib cage, the top of the thoracic cavity. You want to watch for retractions, and that is where those are sucking in. When the patient is trying to inhale, you'll see all of that caving in because they are working so hard, and you'll notice that they are breathing very heavily with their abdominals, and they're trying to pull that air in through the restricted airway.